Good morning, everyone. In today's presentation, we examine underage binge drinking through a behavioral economics lens. We argue that the 2009 Chief Medical Officer's guidance, although scientifically robust, rests on standard economic assumptions, specifically the idea that parents and teenagers behave like Homo economicus, rational, consistent decision makers who process information optimally and adjust their behavior accordingly. But the CMO extracts tell a different story. Parents are expected to absorb information, communicate risks to their children, supervise consumption, and set boundaries. Teenagers are expected to internalize long term harms and adjust their behavior. And this is precisely where traditional policy design fails. Our goal today is to show which behavioral mechanisms undermine the effectiveness of the current policy, how a behavioral economics informed alternative can work better, and why this new design systematically aligns with how people actually make decisions.
Our starting point is the 2009 UK Chief Medical Officer's guidance, which states very clearly that children under 15 should not drink at all, and that parents should play a central role in setting boundaries, supervising behavior, and communicating the risks. The guidance is significantly robust, but it relies on a very traditional assumption that if we gave parents and teenagers information about harm, they will understand it, weigh it against the benefits, and then make a rational decision. In other words, the CMO guidance expects both groups to behave as if they were rational optimizer. What economics would call Homo economicus. The policy rests on the idea that understanding risks leads directly to reducing risks. But that's not how people make decisions around alcohol. Real behaviors is shaped by cognitive limitations, emotions, identity, and social pressures. And for both parents and teenagers, these behaviors tendency predictably undermine the way the guidance is intended to work.
And we know that behavioral economics theories show that decision making is subject to four fundamental principles. The first being, people do not always optimize effectively. Their behavior is shaped by reference points, they struggle with self control and present bias, and they care deeply about the behavior and expectations of others. Which is why we see that these principles help explain why information-based policies often fail in practice. When teenagers weigh outcomes, their decision-making shows hyperbolic discounting. They disproportionately overweigh immediate rewards compared to future harms. The short-term benefits of drinking, such as social acceptance, confidence, the sense of excitement, dominates their choices in the present. And in theory, if teenagers discounted the future exponentially as well as consistently, they might respond to the CMO warnings more effectively. However, in reality, hyperbolic discounting means that the long-term neurological harms that are quite emphasized in the guidance barely register in the moment. The risks are too abstract and too distant to shape behavior when it really matters, and therefore the CMO's guidance fails where its core assumption depends on those harms influencing behavior. Teenagers also suffer from salience failures. Their developmental harms in the guidance that are highlighted are cognitively invisible at the moment a choice is made. For example, at a party surrounded by friends, we see that teenage behavior is so strongly shaped by social preferences, they often mirror what they believe their peers are doing as the correct way. So if drinking is seen as normal, then the impression alone is enough to override health advice. And at the same time, we see in parents how they show equally important behavioral tendencies. Many rely on heuristics, such as believing that supervised drinking is protective or teaches responsibility, even though evidence shows that early supervised drinking actually predicts heavier use later in life. Parents also display optimism bias. They believe that the harms apply to other people's children and not their own, when the guidance explicitly says that the harms of drinking are across the board, regardless of the situations in which they are used in. And importantly, parents often misperceive the behavior of other parents, which leads to pluralistic ignorance. Each parent thinks others are more permissive, which pressures them into allowing alcohol, even if they personally feel uncertain. And when we look at the CMO through this lens, it becomes clear why the guidance, although well-intended, struggles. Its instructions to parents assume that parents can easily overcome biases, avoid social pressure, and possibly enforce long-term boundaries. Essentially, that they can behave rationally at all times. But in behavioral terms, the policy overestimates parents' and teenagers' cognitive capacity and therefore underestimates the influence of context, emotion, and norms.
And in fact, 1 in 6 parents allow their children to drink alcohol at home, and the children who drink, 76% of them have reportedly consumed alcohol at home. So given this, we redesigned a policy to align with how people actually behave, because most teenagers access alcohol through family networks rather than by purchasing it themselves. We target parents directly, but instead of giving more information, we change the decision environment. So our recommendations have 4 components. The first one is default alcohol-free parental agreement. Parents are automatically enrolled unless they actively opt out. This leverages status quo bias and limited optimization. Many parents want to restrict alcohol but find it hard to follow through in the moment. So the default supports them by making the protective choice the easiest one. Opt-in versus opt-out policies exist in different scenarios, like organ donations. This is akin to libertarian paternalism, whereby the state takes on the paternal role by nudging people to behave in a particular way without forcibly restricting behavior. The second component is social norm feedback. Parents tend to overestimate how many others supply alcohol. By providing anonymous data showing that most parents do not, we correct this false belief. This directly uses social preferences. Once parents realize that restricting alcohol is actually the norm, it becomes much easier to act accordingly. And the third component is timely reminders at high-risk moments, such as before holidays, parties, or school events. These prompts counter present bias by making long-term intentions more salient just when short-term pressures arise. Instead of expecting parents to remember the guidance at the right moment, we bring the guidance to them. And the last one, the fourth component, is identity-based framing. Messaging emphasizes that not only supplying alcohol aligns with being a responsible and protective parent. This shifts the reference point. The default self-image becomes the parent who protects their child by setting boundaries, rather than the parent who avoids conflict or allows supervised drinking. So taken together, these interventions make the responsible choice easier, clearer, and more consistent with parents' values, but without introducing coercion or punishment. So the idea is to not change the attitudes, but to support better behavior through the redesign.
So now we turn to why this behaviourally informed intervention works more effectively than the existing CMO guidance, and why it outperforms alternative information-led approaches. The CMO guidance is built on the assumption that parents and teenagers can override their biases through rational deliberation. It provides information and expects this to translate directly into behaviour change. Yet behavioural evidence consistently shows that this expectation is unrealistic. Parents may understand the developmental risks of alcohol, but in real decision moments they are guided by social pressure, immediate convenience, and the false belief that other parents allow it. Teenagers, meanwhile, heavily discount future harms and are shaped by peer norms. An information-heavy strategy depends on cognitive capacities that routinely fail under these conditions. Our intervention works precisely because it accepts these constraints and uses mechanisms shown empirically to overcome them. The use of default effects is supported by strong evidence, particularly in organ donation, demonstrating that opt-out systems dramatically increase organ donation consent rates, showing how defaults reliably reduce cognitive load and shift behaviour. By embedding an automatic alcohol-free agreement into school processes, we apply the same principle. Parents who intend to restrict access but struggle in practice receive structural support, something the CMO guidance entirely lacks. Norm feedback is grounded in research showing that parents report lower perceived approval of alcohol use after viewing normative feedback. This directly tackles pluralistic ignorance, which is a major driver of permissive behaviour. Unlike the CMO guidance, which does not address distorted social expectations, our intervention reshapes perceived norms using verified behavioural evidence. Timely prompts draw explicit on in-just-time adaptive intervention research, which shows that prompts delivered at moments of vulnerability are among the most effective techniques for shifting behaviour. Decisions about supplying alcohol happen at exactly these moments, that be it before parties, holidays, or social events. The CMO guidance relies on parents recalling complex risk information during emotionally charged situations
and from the evidence we can see that this is a fragile assumption. Our approach removes this reliance by increasing salience at the precise moments decisions are made. Identity signalling shows that behaviour becomes more consistent when framed as an expression of a valued identity. By positioning non-supply as part of being responsible, protective parents, this intervention strengthens motivation and stability over time. The CMO guidance encourages parents to set boundaries, but does not connect to identity, missing a powerful evidence-based lever for durable behaviour. Across these mechanisms, the pattern is clear. Every component of the intervention is backed by empirical evidence, but more importantly, each one tackles a behavioural failure that the CMO guidance simply does not engage with. Status quo bias, pluralistic ignorance, present bias, failures of salience, and weak identity alignment continue to shape real decisions because the current guidance treats them as if they don't exist. That blind spot is not a minor detail, but it's the core reason that the existing policy struggles to translate knowledge into action. So taken together, our intervention works because it doesn't rely on perfect reasoning or long-term preferences. It instead changes the environment rather than demanding people change their psychology. The mechanisms we use are not theoretical add-ons. They are tools repeatedly shown to shift behaviour in practice. By making the protective choice more salient and socially reinforced, the intervention compensates for exactly the points where information-based guidance fails. For these reasons, a behavioural intervention built on evidence-backed behavioural mechanisms is not only more realistic, but more aligned with how decisions around alcohol are actually made. And because it addresses the behavioural drivers that the CMO guidance leaves untouched, it stands out as a more effective and more credible route to reducing underage drinking.